Gordon Smith's email is available later. You guys are really hardcore to come to a presentation on the MACRA final rule at 3 o'clock in the afternoon. Then I realized that I'm actually doing sort of a 301 level presentation on the proposed rule. So it just couldn't be more deadly. And I was walking down the hall and Bill Whitmore goes, "Good luck." I hope everybody has coffee. So I hope you have your coffee, and we're going to dive right in. And I actually think that David Blumenthal did not only just an astounding job on his presentation, but he really teed this up nicely by talking about the Affordable Care Act, because he talked about sort of the coverage and the challenges of bringing people into the healthcare system. And I would propose that MACRA, the legislation that came after the ACA, is actually going after the fundamentals of healthcare. It is a fundamental change in how healthcare is delivered and paid for. So you're never going to get coverage if you don't have that works, if you don't have the fundamentals right. So it is a profound change. Talking about the changing an industry that is the size of France. We are talking about shifting $20 trillion around, and there are plenty of interests who really benefit from the status quo. There is absolutely nothing easy about this. So with that, we will talk a little bit about what the proposed rules do. I'm assuming everyone has a basic understanding of MACRA. MACRA repealed the unsustainable sustainable growth rate, which was the political frenzy every year where 30% cuts were proposed to physicians and then they weren't. And this really is shifting payment away from fee-for-service to value-based payment. And the assumptions embedded in making that possible are fairly profound changes. So with that, I'm going to start with the punchlines. Based on sort of the shift from the original rules to the final rules, short-term impact really is going to be minimized. And we're going to talk about that for a while, some of the changes that they have put in place. There are going to be more ways to participate. CMS wants more people in alternative payment models. There are new ways to create alternative payment models, new programs that are open. So there will be new ways to participate. Data and effective measurement will be essential. Dan, you are going to be really busy because no one is going to succeed under MACRA without access to adequate data and really a rational approach to measurement, which I'm a former board member of the National Quality Forum. I say this with all due respect, we are not there yet. And change is delayed but inevitable. I would say MACRA is not going away. It doesn't matter how much you don't like it, it is not going away. So even if some of the penalties come later, this is still happening, so be ready. So the basic timeline remains the same. This starts, everybody, January 1 of 2017. It starts, ready or not. And the recent surveys show that maybe 50% of physicians have ever heard the term MACRA. So they could be surprised in 2019 when they actually get payments from their performance in 2017 based on MACRA. But nevertheless, it is starting. And there are multiple pathways. MIPS is MIPS, there are so many acronyms. The merit-based incentive payment system is going to be the most common. They're familiar with that. We'll talk a little bit about that. There are also new alternative payment models and advanced payment models that will be kicking in right away. But the timeline starts January 2017. The big change in the final rules compared to the proposed rules is something they're calling pick your pace. They heard from the physician community that people were not ready. And particularly among small and rural practices, they didn't even know what it was, let alone how to manage risk, how to get the data systems in place. So they have, in my view, made significant concessions to that. And to be really honest, it would be really hard to get a penalty under MIPS right now. It's basically doing absolutely nothing, absolutely nothing. If you submit, one measure, one small bit of data, you will avoid the penalties. So they have really the submit something section, that's if you are doing any quality measurement right now, if you are doing any clinical practice improvement activities, basically any data that you can submit demonstrating that, you will avoid the penalties. There are more aggressive options, and there will be higher payment adjustments if you do more. The sort of all-in option is submitting a full year of data. And they are, CMS as recently as Tuesday said this, they really are encouraging practices that are ready to start that so that you can get used to this whole approach. The penalties are minimal at this point, so really getting your practices ready to submit data regularly, full data, is really probably will position you best for the later years where the penalties really kick in. So it really is worth thinking about how to get practices ready to even participate in a minimal way. But it is also important to remember that the payments are not attached to the amount of data that you submit. The payments will be related to your performance against the measures you submit. So you get to pick your measures, but it is still going to be the introduction to payment based on measurement. One other thing I should have said is I will take questions literally at any point. If you have no idea what I'm talking about, I would rather know now. So anytime, raise your hand, jump in, whatever it takes. I am happy to try to answer your questions. The other disclaimer I should have made is I am not from the government. I did not write any of this. I am just telling you what it says. One of the other big changes that it's a little tough to swallow if you're from a multi-stakeholder perspective, is they took out any resource use measurement in year one for MIPS. It was going to be 10% of the weight for your score, but there is now no resource use measurement initially. You have a question? Yes, Bob.
Is the measurement by individual providers at the practice level, or is it the system level?
It's individual providers, but it can roll up to the practice level. And if you're in an ACO. And actually, there was a question with CMS just Tuesday. You know, will these scores sort of follow the physicians around? Because they are required to publicly report them on Physician Compare. And they're going to take sort of the most conservative approach possible, recognizing that this is new. But these scores will track with individual physicians unless it's rolled up to the practice level. So I'm happy to go into more of that if I can. So the reason CMS says that they took out resource use for year one is they were not comfortable with the measures that were available. They just didn't think that they were adequately reliable, and it really counts now. So they want to make sure that they have resource utilization measures that are credible because there are penalties attached. Now, what's interesting is that Congress actually wrote in that by 2021, it's still going to be 30%. So it can be zero now, but it's still going to be 30% in 2021. So the advice is really to get started. Even if it doesn't count now, get started looking at your resource utilization. You know, wherever you get a QR/UR report from Medicare, get a total cost report from a Maine Health Management Coalition, but whatever it is, get your utilization data so that you can get comfortable with understanding your utilization patterns. And by 2021, where it does really kick in, you will have some familiarity and practice with that, at least. Sorry, one other thing that I want to say about this, advancing care information stays at 25%. This is really going to be about the interoperability, data sharing across practices, across sites, across facilities. And there is a big push from the Office of the National Coordinator right now. This is a little bit outside of the MACRA rule, but it is very related, to really emphasize sort of standard data sharing and really put more pressure on the vendors to make that possible so that they are really assuming the ability to share data across sites, clinical data in particular. All right, please don't ask me to explain this slide, but the point really is that even though the sort of non-participation downward adjustment is still there, in the early years, you know, it really is, it requires minimal participation and minimal activity to really avoid any penalty. So it's really, again, it's still downside risk, but it's much easier now to earn the positive adjustments. They've also, because they heard so loudly and so clearly about the potential impact of small and rural practices, there are new exclusions. So low volume clinicians are excluded. So now they really expect in the first year only 60% of clinicians are going to be in MIPS. So this is a concession, flexibility, whatever you want to call it. They are now excluding more and more physicians from at least the early years. And I will say, I have been struck by the responsiveness at CMS. I actually work with them on a fairly regular basis. And apparently Andy Slavitt told all of the senior leadership at CMS, they were all ready to start writing the final rule, called them all into a room and said, put your pens down. Do not write a single word until you have gone out and sat in practices. You have watched them try to enter PQRS data. They said they heard language they had not expected. And you've really learned what it's like on the ground. And I will tell you, all of those leaders, Jean Moody Williams, Kate Goodrich, all of them, I think it really impacted how they are trying to do this work. So again, the rules are still complex, there's still 2,400 pages of them, but there really is an attempt to be responsive, be flexible, but still meet the objectives of the legislation. It doesn't always come out that way after OMB has its way, but it is still, that is the intention. And this is a major difference. I actually used the proposed rule version of this graphic last year, as did Congress when they hauled Andy Slavitt up to explain it, because it showed major negative impacts for really small and rural practices from the proposed rules. So this is with the exclusions, and this is with some of the changes that they've made, the pick your pace. This is supposed to have a much lessened effect on the really small and rural practices, because they recognize the challenges of the change expected. And to assist with that change, there is $20 million set aside for technical assistance to small and rural practices. This is actually in addition to all of the other programs that they have put together. And we tried to make them orderly. I know Lisa's thinking death by technical assistance, because there are lots of programs from CMS. They want to help, but it is really going to be incumbent at the community level to organize this in a way that makes sense. Getting 5 different phone calls from uncoordinated technical assistance providers is not going to help anybody. You have a question? Yes, hi.
Hi. Elizabeth, is this still supposed to be budget neutral if it's easier to be a winner?
Yes. So Sarah said, is this still supposed to be budget neutral? And the answer is yes, because it is in statute that it has to be budget neutral. So that means the incentives that are going to the high-performing practices are coming out of reductions from the lower-performing practices. What they are trying to do now, I've had several talks with them over the last week, is say, well, some of it is budget neutral, that overall it's budget neutral, but they are trying to make it less of a downside directly correlated to the upside, but in statute it still has to be budget neutral, so yes. However, there are additional incentive payments for the first 6 years, like considerable money. Like that's actually one of the reasons they wanted to start it as soon as it did, because those additional payments sunset. So there are quality incentive payments on top of the program payments, at least initially. But yes, ultimately, and it goes up to a 9% variation, so you could lose 9% of your revenue from Medicare with low performance in the out years. So anyway, lots of technical assistance, but again, my point is that if you can collectively, as a community, organize a way to make this make sense with learning collaboratives, with, just making sense of this for practices and really understanding what the resources are there. Practices need help succeeding under this new complex rule. This is like chutes and ladders of payment reform, but they expect about 70,000 to 120,000 clinicians to qualify for APMs. This is sort of, are you an APM? Are you an advanced APM? This is really, this is something that you can look at as a practice to understand if you're in or you're out, but there's more detail available on that. So, short-term impact is minimized, but there are going to be more ways to participate. And CMS, the way they're looking at it, they're really emphasizing categories 3 and 4. So they are excited about bundles and population payment. And that is where they envision everybody eventually migrating to. There is another group called the Healthcare Payment Reform Learning and Action Network, and they've sort of modeled out their transition. They've got white papers, but I mean, think basically they will be looking for models that are around bundles and population payment. These are the current examples. So we don't know the complete list yet of APMs that will be eligible initially, but we know some of them that aren't. MSSP, ACOs, Track 1, and I know those are in Maine. Basically anything with one-sided risk is out. To qualify as an APM or advanced APM, it's going to require a downside risk. If there's one differentiator, that's it. Everyone, I guess this only happens in Washington, but advanced APMs are the hot ticket. And CMS thought sort of there's going to be this rush of advanced APMs, but they are really saying, don't go there unless you're really ready. Don't take on significant downside risk unless you really know your partners, your practice team, you really know your data, that you've done this before. They are actually hoping, I believe, for fewer in the advanced APMs, and they're trying to make MIPS and the regular APMs more attractive. Their words were, don't go whole hog into downside risk. That's a quote. And one other thing that I would just want to call out here is ACOs are actually forbidden from using stop loss to back up to pay for losses, because they really don't want to avoid the incentives that are there. So you can't get around the downside risk is basically what they're saying. So they are looking at additional primary care-based models, and they are looking for community-based models. They have expanded the definition of physicians to include other types of caregivers. So they're really looking for things that, in my view, are fairly creative. So here's your acronym of the day, the PTAC, the Physician-Focused Payment Model Technical Advisory Committee. We were created by Congress, because I am somehow the vice chair, and we are tasked with identifying innovative physician-focused payment models to recommend to the Secretary to add to the CMS portfolio. Because we were created by Congress out of frustration with CMS, you can imagine that we are super popular with CMS, but we are actually, I think, developing a fairly effective working relationship, because we have the shared aim of really expanding the portfolio of alternative payment models. And the cool thing about this committee, in my view, is that we are hearing directly from the field. We are inviting payment model proposals from physicians in everyday practice. And we are saying, if you can show us that this can work, we recommend this for inclusion in the Medicare payment portfolio. So it's pretty exciting. We have had like standing room only crowds. I didn't think anyone knew we existed, but people show up. We are up to 35 Twitter followers, so we're getting there. Maybe 40 after today, I don't know. But we are really to bring the voice of physicians in the field into CMS thinking, which is, I think, really cool. This is just a really basic thing. There are 11 of us. Physician-focused payment models, it's a little unclear. They are not necessarily alternative payment models. They are not necessarily advanced alternative payment models. But if you have a physician-focused payment model that meets the criteria of an advanced payment model, then you're good. So, but there's a lot that we're working out, sort of what qualifies. We are directed by the Secretary to identify models that obviously pay for higher value care. I mean, the basics here are it can't increase cost and it has to improve quality. So that's sort of nothing will go forward without those dimensions. We're looking for better care coordination, patient safety, really encouraging patient engagement, and there's a lot of emphasis on information sharing and effective use of data. We have come up with our own priorities as a committee. Well, actually, CMS is really interested in scope. I mean, it's really cool if this works in Augusta, Maine, but it's even cooler if it can work across the country. So they want things that are scalable, even if they are tested in regions. Quality and value, flexibility for practitioners, and we are not just talking about tweaking fee-for-service. These are really alternative approaches to payment that we're looking for. And we start accepting proposals on December 1st, so there is some time to be the first ones in. We started accepting letters of intent a couple weeks ago, and we've gotten 2 already, the American College of Surgeons and somebody else. And we will be, our goal is to actually have new payment models approved and in the field by 2018. All right, we're on to number 3. Data and effective measurement will be essential. So I would love to spend this whole time talking about data, but I promised I wouldn't do that. So, but again, the data aspects of this are significant. We will not go into detail today, but basically this is how most providers seem to feel. So at every hearing that we've had of PTAC, from the AMA to the cardiologist to the community physicians, they come in and they say, we would love to design a payment model. We don't have any data. We don't know how to get the data. We don't know how to use it. It seems to be the singular barrier that they are all facing. So one of the things that we are talking about is how we can make that more available to those who are trying to do that. But it remains a significant issue, and particularly if you're looking at commercial and Medicare data combined, but we'll talk a little bit more about that. So this is actually from one of my members in Oklahoma, and if they can do it in Oklahoma, I think it's doable, but they have really been successful at CPC, the Comprehensive Primary Care Initiative, and these are some of their takeaways. And this is, if we were really successful in Maine and everywhere, we'd have multi-payer data and multi-payer alignment. We'd have patient-centric, community-wide data. It doesn't just stay in a practice or stay in a facility. It actually follows the patient through the entire community. Physicians would have point-of-care access. There would be a clear understanding of attribution and risk. You're not surprised. I didn't know that was my patient. I didn't know how to connect. Active alerting, community-wide quality measures, understanding cost and utilization, and managing care transitions. So this is sort of what I think we need to create as everybody's abilities to be successful, but we're a long way from that. So, well, I don't know if you are, but most of the country is. And then, MACRA has all sorts of provisions for data sharing, but they have done nothing, in my view, to make sense of the measurement and to make sure that the data enables measurement. They have new rules for comparability, which basically means you can pick any measure you like, and as long as it's sort of comparable with what other, what MIPS is doing, you're good. So good luck trying to standardize, trying to create benchmarks, trying to look at what others are doing and how they're performing. I think that's a major issue. But they are planning to give additional data to providers, the classic QR/UR reports. They're hoping to expand those. But again, there's a long way between what they're planning and what we need. This is sort of the other, oh dear, this is a big build. This is sort of the vision, again, from Oklahoma, how they have achieved what they've done. They have all of the claims and clinical data coming together in a sort of regional data set. The providers and the payers and the purchasers all govern that data set, and they share this information across the entire community. They're using it for payment, they're using it for measurement, they're using it for improvement, and it really is an asset that has enabled them to be extremely successful in CMS programs, but also with private purchasers. And again, it is a model that ONC is looking at, that CMS is looking at. How can we get this level of data access available across the country? Again, we have a long way to go, but there are glimpses of it. One other thing that I just want to mention on the measurement front, this just came out about a week ago, and it will not tell you anything that you don't know already, but value-based purchasing essentially assumes the availability of meaningful metrics. That's a problem, that assumption, because those metrics really aren't available and established. And I think I pulled out a few of the key things that really struck me. Across commercial health plans, they found that only 5% of measures are common. So you're not imagining that you're being asked to measure different things for all the different plans. They quantified what they cited was physician practices spend 785 hours per physician per year on quality measurement, and at an average cost of about $40,000 per physician per year. That's crazy. So they are really pushing for some sort of rationalization of this. They have created various forums with private commercial plans to say, can we at least have a core set of metrics? We cannot burden practices with this chaos. So again, it's not clear what levers are there to actually make that happen. I actually spent a year and a half with David Blumenthal, who was the chair of the IOM Core Metrics Committee, coming to consensus around what metrics would really matter. If we picked, let's say we picked 10 as a country, we couldn't get past how to implement. Nobody could say what entity could decree these are the metrics that everybody's going to use. So we gave it to the secretary and said she'll figure it out. But there is a lot of thinking about what measures matter, but getting those aligned, having that make more sense, we've really got to come to grips with that as a community and as a nation. So this was actually from my board chair, who said, what we would recommend is really having that combined data asset that follows the patient. You've got to be able to see your whole population. You can't manage a population without population data. Quality improvement has to be aligned with what's really happening in your market, and stop the madness, standardize the metrics. All right, we're on to the very last one. We've made it. So change is delayed, but it is inevitable. MACRA was bipartisan. It is maybe the only major bipartisan legislation that any of us have seen in a very long time. I was, by some weird accident, I was invited to the sort of signing ceremony at the White House for this, and everybody was just so excited. I don't think any of them knew what was in MACRA, but they were so excited that they had done something together. It was literally Nancy Pelosi hanging out with John Boehner celebrating something. So I don't think this is going away because no one understands it. And I mean, this was major legislation that was passed with both sides of the House. So it's here to stay. And frankly, I think that the rules are quite reflective of the intent. But this is actually the real reason. People are responding to a truly unsustainable burden on families. This is not an academic exercise. All the money that is, we talked about it in the last session with David Blumenthal, this is coming out of communities, out of wages. Healthcare inflation, and you probably all know this, it's taken up 10 years worth of wage growth. We cannot sustain this, and it is now really burdening families, as we know. So this is not just to move deck chairs around. There is really an attempt to address the cost and quality of healthcare to make it more sustainable and affordable. And also, CMS is really projecting savings. They are seeing early signs of significant savings through their payment models. And this is very compelling. And if we can achieve these, we are going to make a dent in that France-size economy. But it is not an easy lift. They are also seeing particular success, in their view, with multi-payer models. This is from CPC Classic. They have just announced they will be expanding CPC Plus because there has been interest around the country. Those are primary care-based, multi-payer or all-payer models. They believe that there are real savings to be had in better care through a primary care-based initiative of aligned payment. They are also not shying away from some really innovative approaches, and again, multi-payer is the theme, but they're going with they are endorsing and supporting and promoting Maryland's all-payer hospital rate regulation system. And I would say look for more things like this. And not to give away a headline, but I'm going to give away a headline. We just did a total cost of care analysis, Judy, across 6 states, and it really shows that Maryland had the lowest cost. And we can't attribute it exactly to the regulations, nor would they, but there is something there. It is really having an impact, and that is on commercial costs. This is Medicare. We're talking about commercial. And again, as you move through the out years of the rule, to qualify, you are going to have a higher percentage of patients in alternative payment models. You won't be able to do this through Medicare alone, unless you just have so many Medicare patients. This really assumes multi-payer participation, and in my personal view, presumes the availability of multi-payer data. Again, you can't manage a population that you can't see. You have to have visibility across the panel. And this might be gratuitous, but this is what we hear from all of the payers, all of the providers. It doesn't matter how innovative one plan is. If there are conflicting signals, it's just noise. We've got to have alignment across the plans. And it's measurement, it's incentives, it's models, and to say it's not your average bureaucrat in there these days. Andy Slavitt was quoted this week as saying, all the ways that health plans in many respects use to differentiate themselves just annoyed the crap out of doctors. Just stop. So that's from Andy Slavitt. So this is a very different dialogue that's going on. Now, of course, he's out in 2 months, but so you can say these things. But it's really just a readiness to take on some of the harder issues. And they have to have multi-payer participation. They want the commercial plans at the table, but they want alignment for measurement, alignment for incentives, so that practices can actually move forward in a coherent way. Michael.
I get it, and that's what everybody wants. And the RFIs coming out from CMS want to know how you can do that in states to be funded. Then why did they let the providers to pick their own measures under this?
I told you I didn't write it. I couldn't agree more that there is some inconsistency there. And I have asked them that exact question. I think they are wrestling with that internally. And there are some conversations as recently as this week. Can we come up with a couple of common metrics? But they heard the providers saying they weren't ready for some of the expected measurement protocols. And so they are trying to give them flexibility. It is my bet, don't quote me, I think they are going to move towards common metrics, at least a few common metrics that will be expected across the practices, but it's not there yet. And one other thing, they actually left open comment periods. Even though the rule is final, there are this is unusual, but several areas are still open for comment. So feel free to share that one. All right, so implications for employers. This has to be multi-stakeholder because the employers are key to moving in this direction as well. Actually, I was in Louisville, and we brought a lot of large employers together. We had 250 people show up because they wanted to figure out how to make MACRA work for their community. We had the plans, we had the providers, we had patient groups, we had employers. It was really remarkable. But the people most excited were the employers. So they said that we finally have the world's largest purchaser moving in the direction that we have been wanting to go. Now is our chance to really, really shift the market. So, hopefully that is how it plays out. But there was a lot of optimism that, at least in that market, really working with your plans to move in the same direction so that it is coherent and that the signal is amplified. And really pushing for more advanced models. I work with some large employers like Walmart and others, and they're a little frustrated. They think the models just aren't quite ambitious enough in terms of cost accountability and savings. So, and they're saying, well, let us model some of the more aggressive ones, and then maybe those can be adopted by Medicare. Either way, but now is seen as a time of flexibility and innovation. Some additional insights, I'll just leave that. But what can employers do? Really become familiar with them, identify your priorities, are your big spends in maternity, orthopedics, and really, I've talked to these employers who are trying these direct bundle contracts. They're just trying things because they know that something has to change. So, and to the extent that you can align with other employers and with Medicare, hopefully it'll just move it forward. And again, this was just from Diana Hahn at GE. engage in the discussion of value-based contracting and leverage your purchasing power. So, almost done. The key takeaway here is that basically the historical state of fee-for-service, I guess it is end of life. It's on its last legs, as David Blumenthal said. I don't think it's going to go away entirely. I don't even think it should go away entirely. But there is an aggressive move towards value-based purchasing, new forms of payment, medical homes. Transparency is going to be essential. This is actually a CMS slide. It's going to be presumed, and really looking at more patient-centered, outcome-based care. But what it really comes down to is what you do in your community. It's a policy framework. It's complex, but it is in place. And I really believe that each community, by aligning employers and plans and providers, is going to determine your own success. And really identifying what you each can do to make your community successful is the real task. So everyone's at least still awake, which I am really pleased by. And I am happy to try to answer any questions. Again, this is a 2,400-page rule that came out about 10 days ago, so I won't have all the answers. But I am more than happy to have any dialogue that is of interest. Michael.
So, and maybe I just don't understand the rule enough, but you said earlier on under MIPS, the recording or the measurement is going to be at the provider level, it can be rolled up in practice. So I have a couple questions there. Will that be publicly available? And is there downstream sometime to include commercial data in that? And I think I've read something about that, but I don't know. And then the second part of that is under the alternative payment system, I think the recording is probably at the 10 level.
Yeah, that's right.
And so is there going to be any measurement at the provider level? So if large systems can do all the reporting through ADM, then that's what you have, right?
That's what you have, yes. And I don't know, I would invite anyone else to speak on this as well who might know more, but the TIN level really is about as far as you're going to be able to go for most of this. And it is not granular enough for improvement. It is not granular enough for accountability. They are trying to go to provider level reporting, but they don't have all the mechanisms to do that. I don't know, anyone else on that? Lisa?
That's all the more reason for continued local efforts, because it's going to take them forever at the CMS national level. So great opportunity to take this.
Yeah, and they are required to publicly report on physician compare at some point. But as I said, the signals they are sending now is they are going to be as careful and conservative and cautious as possible so that it is right.
The proposed rule said at the discretion of the secretary. I don't know what the final rule says, but I assume it has similar language.
Yeah. Yes,
One of the
Dan.
things I like about the MIPS program, at the MIPS level, practices now have the choice of reporting at the provider or the TIN level, the MCI or the TIN. And at that choice, it carries through all of the performance categories, which is an enormous improvement on meaningful use, where it follows you through all your practices and all your history. Now it's at the practice MPI level. And when you make that choice to move to the G-Pro, or the group practice reporting option, it follows you with all of those categories. And it becomes a much simpler process. And then you get reported on physician compare depending on how you chose to report at the NPI or the TIN level.
And couldn't everybody just choose 10?
Well, there's going to be strategy around that, because you might have a better outcome as individuals, or you might have a better outcome as a team. This is a complicated program. Don't try it at home alone.
Call Mingle Analytics.
Wear your protective gear.
So, from what I've heard is you want to start out well, because let's say you stick your head in the sand and we're not going to do this and we're going to wait until later, and you start getting the -4 and then the -5, and all of a sudden you realize, oh my God, we need to do this. If the next year you do it all well and you get a good score, it's not like you're going from -5 to +6. You're going from -5, and if you do everything well, you might go to like 1%. Is that how you understand it?
So yes. I actually, you all know Eric Steele. Eric Steele came and did a presentation for us in North Carolina recently, and he said what he's saying to his physicians is just start. It doesn't matter the details of the program, where you're getting your data, and who is on your team, and what is your current performance. So regardless of the details, you're going to need to know those basics. So to your point, don't put your head in the sand. That's exactly right. By 2021, when resource use really counts, you should have some proficiency there. And understanding your performance now and your data access now is really, I would think, an advantage. Yes?
And you really need to look at all the components, because you can do great on quality.
Right.
If you don't submit the practice improvement, well,
Yeah.
you lose
That's
all
exactly
those
right.
points. And a lot of those practice improvements, it seems like a lot of practices are probably already doing them.
Well,
they
exactly.
just need to say we're doing this, this, and this to get points for it. So if you could be doing great on quality. If you miss 15 points, you could go from having a really good score to I'm getting dinged.
Yeah, and the clinical practice improvement activities, the list is pretty long. I mean, yeah, I would guess all practices are doing something. So really, it is worth understanding it and really and participating initially, because you're probably going to be doing reasonably well, better than you expect. Yes. Yeah.
Two questions for you. One, how does the system account for the movement of patients? So it assumes that the patient set remains fairly constant. I see this whole thing about measuring the population in a community, but that still assumes very little movement in the patient set. And that's not really a reality.
Yeah, I am not going to be able to give you an adequate answer to that. I mean, attribution is a big issue here. And also, one of the things that I think the providers fairly are concerned about is you can't do anything with the incentives, with the patient incentives under Medicare. You can't change benefits. You can't steer, really. So if they decide to go somewhere else, are you accountable? And there's not a lot of leverage there. And I think it's going to be incumbent on the practices to really, some of the conversations that I've been part of is how do we make the patients want to be there, really thinking differently about sort of more of a medical home approach. But that doesn't answer your question
Or
about how you
conversely,
measure that.
how do I push patients out that I don't want in my
Okay.
practice?
Yep, I'm sure that's
So
happening
that,
as well.
that's the other thing. And then my other question is just to understand, are the practices benchmarking year over year against themselves, or is there an overall benchmark that they go above or below across the universe?
There are several conversations about that because there are not adequate financial benchmarks now. So they are talking about developing regional benchmarks and national benchmarks. I'm hoping someone else in the room knows how they're starting, because I think there are not at this point fixed thresholds that I'm aware of. And that is what folks are looking for. They want to know what the target is.
Well, it's hard to understand how it can be budget neutral unless you rank against each other.
Well, it is.
Because then there's the top money goes to the bottom, and the bottom money goes to the top, and so you have to rank against each other to
Yep.
make that happen.
And that is how it will start.
One of your slides said that providers are going to be spending 750 hours per year.
That's current. That is the current assessment from the GAO, is they're spending over $750 hours a year. The practices.
That's practices or per provider?
Well, it was estimated per provider.
That doesn't leave a whole lot of time.
I agree. Well, and the entire point of the report was like, that has to stop. Because we've got to get a more rational measurement system that is not taking the physician time and the resources. So they were quantifying that to really define the problem, because the push is to actually do something about that.
So are they going to measure that change or that deficit that people spend less time on? Because one of the major reasons that doctors getting out of practice was
Yeah, I don't know the plans for future measurement. I think the fact that it is absolutely a key part of the discussion. It is increasingly front and center in the policy conversations. But as Michael pointed out, they're still not requiring common measures, they're not even requiring comparability. So they know the problem, but I don't see the clear solution yet. I wish I had better news. Yeah.
One question. They created the MIPS APN track this time in the final rule, which incentivized people to move to MSSP1, where you don't take any financial risk while you enjoy the 5% bonus and have zero for cost. That gave us a safe harbor.
Yep.
Do you see this continuing on the long term, or is this an interim strategy?
I think it's interim. They are trying to get people into the program now, and I think there are going to be growing expectations for downside risk. They are not going to leave people in upside only getting incentives. And the incentives, so those additional incentives are time limited as well. So I think, again, I'm not CMS, I think it's interim. Yeah, Kim.
I'm not sure they address this, but if they're moving away from fee-for-service, and since most of the measures at this point are based on claims,
Yeah.
how do they address anything on the data source? And in fact, I do understand that the final measure specifications that they haven't released. But I assume that they have to address the issue of what the data sources would need to be.
Yes, I have the same assumption and the same question. I mean, honestly, if you look at the metrics that are in the pipeline through the Measures Application Partnership, it's pretty standard HEDA stuff. There is nothing particularly exciting about it. So there's a lot of conversation, and actually there is money in MACRA for innovative measure development, and CMS is now starting to solicit ideas for better measures. They want to move to outcome-based measures, patient-reported outcomes. They don't have the data infrastructure to do that. So I mean, if I had to bet, I mean, for the next 2 or 3 years, it's going to be those pretty standard, claims-based, HEDIS-like measures, with the attempt to move to the clinical metrics and patient-reported outcomes. But it's going to take a while because they don't have the data.
We have still about 10 minutes left if folks have more questions. Or if not, we can wrap up early.
As complicated as this is, and in my knowledge of history, it seemed to come out of nowhere, shall we say. It seemed like the last, what hothouse, what think tank, what was the process to go from SGR repeal to this complicated multi-level PhD system? And just for out of interest sake, for 30 seconds, what was the history development of this?
Well, I wasn't there.
Okay.
I mean, I think that this has been, maybe Senator King can share some insights about that.
Oh no, this one's yours.
I mean, they knew that the fee-for-service system was a major driver of the unsustainable payment. So I don't know who dreamed up, APMs and advanced APMs. I know several of the people there. They're very, very smart, as you mentioned. But I don't know the exact origins. They wanted to get rid of SGR for all sorts of very, very good reasons. They did that, but then they used that as the opportunity to really make some dramatic changes in payment. And I think on really good days, they are trying to enable better care. They are trying to pay for medical home type models and community-based care. I mean, that is the intention. To the extent that the payment enables that, I think that's to be determined. So sorry, I don't have the story.
I need names, and I need it.